Hello, everyone, and thank you for joining us for our clinical webinar today. My name is Dr. Savannah Clary, and I'm a member of the Aegis clinical team. I will be presenting today's webinar. Please ensure that your phone is muted to help minimize any background noise during the presentation. You will have an opportunity to unmute and ask questions at the end of the presentation today. Our objectives are to list available testing options for dextromethorphan and levorphanol from Aegis Sciences Corporation, describe the metabolism of dextromethorphan and levorphanol, discuss pharmacokinetic properties that impact the testing and result interpretation of these drugs, and review the abuse potential of dextromethorphan and the clinical effects of misuse. A recording of this presentation will be available on the Aegis website. That's aegislabs.com/resources/events. And please contact our Client Services Department if you need assistance in accessing this recording. Aegis offers a number of add-on tests that are available for clinicians to select. Among these are dextromethorphan and levorphanol. Dextromethorphan can be ordered in urine and oral fluid. Levorphanol compliance testing is available in urine. Our client services team is available if you have any questions on how to order this testing. Dextromethorphan is a widely available cough suppressant that has been on the market since the 1950s. Many of you all are probably familiar with this drug. It is found in over 120 over-the-counter or OTC cough and cold medications, either as the sole ingredient or perhaps in combination with other drugs such as antihistamines and decongestants. Many patients purchase dextromethorphan containing products for self-treatment of cold symptoms without consulting a doctor or pharmacist. Levorphanol was originally approved under the brand name Levorphanol in 1953. It is a Schedule II opioid agonist that is relatively selective for the mu-opioid receptor, but it can bind to other opioid receptors at higher doses. The principal therapeutic action of levorphanol is analgesia. When reviewing medication compliance testing results in general, it is important to consider recent prescription and OTC drug use by the patient or any healthcare situations that the patient may have been in which medications could have been administered directly to them, such as a hospitalization or an emergency room visit, etc. As I mentioned, dextromethorphan is available in many over-the-counter cough and cold preparations, so asking the patient about any recent OTC drug use is important. If reviewing for a possible levorphanol ingestion, asking the patient if they have a current or previous prescription for levorphanol, or reviewing the state prescription drug monitoring database can be helpful. It is important to consider if the patient may be at risk for misuse of dextromethorphan or levorphanol. There are limitations with regard to what drug testing results can tell us about this behavior, but evaluation of the patient's history, their current presentation, these are also important components of the patient assessment process. Dextromethorphan has a long-standing history of abuse, particularly in the adolescent population. Intentional misuse of dextromethorphan is referred to as robo-tripping or skittling, among other slang terminology. High doses of dextromethorphan may yield hallucinogenic and euphoric effects, and this is due to antagonism of the N-methyl D-aspartate, or NMDA receptor. Catecholamine uptake is also inhibited, and this leads to adrenergic effects. And dextromethorphan also acts at serotonergic receptors, so a number of different effects possible from misuse. A series of 4 plateaus of clinical effects have actually been described associated with dextromethorphan misuse. The first is mild stimulation. The second plateau is euphoria and hallucinations. The third is distorted visual perceptions and a loss of motor coordination. And the fourth plateau is marked by dissociative sedation. Easy access over-the-counter purchasing these drugs and the low cost of these drugs are 2 factors that may be appealing to users as a drug of abuse. There are multiple dosage forms that are available that can be abused, such as tablets, gels, and liquids. And dextromethorphan powder can also be purchased online or incorporated into illicitly manufactured tablets containing other drugs, such as ecstasy or methamphetamine. Several states, fortunately, have implemented age restrictions on the sale of dextromethorphan products, and this is a positive step toward decreasing non-medical use of the drug in children and adolescents. However, it is still possible through accessing the home medicine cabinet and other avenues that folks may get a hold of dextromethorphan for it to be abused by adolescents and really individuals of all ages. Signs of intoxication from dextromethorphan misuse may include hyperexcitability, ataxia, slurred speech, sweating, hypertension, and/or nystagmus. Toxic effects include irregular heartbeat, seizure, serotonin syndrome, and hyperthermia. Individuals experiencing these effects may require emergency medical care. Especially with the concern of dextromethorphan abuse, a common question related to result interpretation is this result consistent with a patient taking a typical dose, or does this look like abuse of the drug? There are no reference ranges established for expected urine and oral fluid concentrations associated with doses of dextromethorphan or levorphanol, and it's not possible to correlate a drug test result back to an amount ingested. There are several factors that preclude this type of correlation, such as the time since the last dose of the drug, the patient's genetic factors that can affect metabolism, drug interactions, factors affecting the drug absorption and elimination, and other patient-specific factors as well. Aegis provides additional literature on this topic, and we also provide access to our clinical team for discussion of results, and we do encourage you to reach out to us for assistance with interpreting results and to ask us any questions that you might have. The estimated period of detection of these drugs can be used to narrow down the time frame of possible exposure. A positive result for dextromethorphan or levorphanol in urine indicates exposure within up to 5 days prior to the sample collection. A positive result for dextromethorphan in oral fluid indicates exposure within up to 48 hours prior to the oral fluid collection. Dextromethorphan is metabolized by CYP3A4 to 3-methoxymorphanan and by CYP2D6 to dextrorphan. CYP3A4 and CYP2D6 are subject to some genetic variation among patients and also subject to drug interactions, and this can result in varying concentrations of parent and metabolites present even over time within the same patient. Interestingly, dextrorphan, the major metabolite of dextromethorphan, is also the D-isomer of levorphanol, which means the structures are mirror images of each other. Despite their structural relationship, they vary in pharmacologic activity, with dextrorphan being an active antitussive metabolite and levorphanol being a potent synthetic opioid analgesic. Including the metabolites 3-methoxymorphanan and dextrorphan in dextromethorphan compliance testing helps extend the period of detection of the drug, and it can also increase detection when metabolism may be altered either by physiologic circumstances or by other drugs. Dextromethorphan and 3-methoxymorphanan are both unique markers for dextromethorphan ingestion, and their presence indicates recent use of dextromethorphan. Dextrorphan may also indicate dextromethorphan use and will be used to assess compliance with dextromethorphan prescriptions. However, given that liquid chromatography tandem mass spectrometry analysis of dextrorphan is not isomeric, dextrorphan alone can indicate use of either dextromethorphan or levorphanol. So when dextrorphan is present in the absence of one of the unique markers for dextromethorphan, which again are dextromethorphan and or 3-methoxymorphanan. So when dextrorphan is present in absence of one of those markers, then dextromethorphan / levorphanol is what is reported as present. Thus, test results showing presence of dextrorphan alone are not exclusively indicative of specifically dextromethorphan or levorphanol use. In this example urine result, we see both parent dextromethorphan and 3-methoxymorphanan have been detected, and this is consistent with dextromethorphan use. Of note, fluoxetine is present also. It is a CYP2D6 inhibitor, and co-ingestion of fluoxetine and dextromethorphan may have inhibited the metabolism of dextromethorphan to dextrorphan, because that occurs via CYP2D6, and fluoxetine could inhibit that metabolism. Assessing compliance by oral fluid testing requires a few different interpretive considerations. Oral fluid testing includes parent dextromethorphan and the metabolite dextrorphan. But note that in oral fluid, parent drug concentrations typically exceed metabolite concentrations. It is not recommended to assess Levorphanol compliance by oral fluid testing, and I'll explain why. Levorphanol is extensively glucuronidated as a means of clearing the drug from plasma, and concentrations of this conjugated metabolite peak at more than 5 times the concentration of the free and unbound drug. Because only free and unbound drug crosses over into saliva from plasma, the glucuronidation pathway decreases the amount of detectable drug in oral fluid significantly. So clinicians wishing to assess Levorphanol compliance should do so in urine. Glucuronidated drug passes freely into urine, and the conjugated metabolite is hydrolyzed during urine testing to detect the Levorphanol parent drug. Before we wrap up, I wanted to provide you with the contact information for our clinical team. The phone number and email address are on your screen. Please feel free to reach out to us with any questions, whether it's regarding today's content or any other questions you may have about result interpretation or drug testing in general. We're happy to hear from you.